Anybody here using propofol? Okay, good, a lot of you. And when did you start using it? Within the last 6 months? Last year? Last couple years? I think it's becoming more in vogue, and it's going to replace a lot of the other agents that we're using as we get more comfortable with it, and when we can get people to release it to us when they feel we're competent to use it. And that's one of the issues. But great medicine. Basically, it's a GABA agonist, and it also blocks reuptake, so a lot of extra GABA running around there. So it's really going to work for us from that standpoint. And does anyone know why it's white? It's lipid. They have to dilute this and deliver it in a lipid emulsion because it's not water soluble. So they have to make sure they do it that way. What's great is it really looks like a great medicine. It's got to be expensive and worth every penny if it's not clear, right? It's definitely worth more. Great drug. And what's nice about it too, duration of action about 8 to 10 minutes. So we're not going to live with this a long time. And also you can take this back to your nurse managers. You can safely discontinue monitoring 15 minutes after you stop giving the medicine. So if you're giving boluses, you got 15 minutes after that. If you're giving the infusion, shut it off 15 minutes later. No more monitoring is needed, so it's very helpful. All right, so why is the use of propofol in the ED setting controversial? Because we're not anesthesiologists, right? And has anyone heard that urban legend, that myth that, wait a minute, the anesthesiologist in the Department of Anesthesia has to control all anesthetic medications and the emergency department can't have them unless they release them? Has anyone been told that at their hospital? I've heard this a million times. I can't believe no one in this room has heard that. At least, okay, one half a finger, you went like that, okay. You heard it half a time. Okay, great. But that's one of the big arguments we have heard when we're trying to get a hold of this great drug. Is no, anesthesia hasn't released it. Joint Commission says that, that they have to be the ones to release it. Take a look at abstract number 1, and it really helps us because they looked into that myth, and it is not true. It's not true at all, but no one had really written it in an article to really show people that it really is not true. And look at this one from Annals of Emergency Medicine, 2003. There's really a concern about deep sedation. Joint Commission's concerned about it. Anesthesia doesn't feel that anyone who is a non-anesthesiologist is qualified to deliver these medications. Now, they've published several papers from the American Society of Anesthesiology that says that exact thing. Procedural sedation by non-anesthesiologists. And all of those articles have said to date, it shouldn't be done, it's not safe, they're not qualified, they don't have training. But I'm here to tell you, within the last couple of months, I saw an article last week that, that refuted that. Came out from the American Society of Anesthesiology that said, okay, guess what? Non-anesthesiologists are giving these medications. It's not going away. Our focus should be now toward making it safe when they do it, as opposed to prohibiting them from doing it. It's going to open up the world for us here. And so that article is going to become very important for us. All right, so this abstract said that Joint Commission does not prohibit this, and also it's recognized by many, many studies that emergency physicians are very qualified and these medications are very safely delivered in the emergency department. And again, they talk about capnography. If you don't have capnography available, it's time to invest and get it. Particularly with procedural sedation, if you note that that CO2 is starting to rise, well, maybe you're getting them a little bit too deep. And you can avoid an adverse event and avoid maybe an intubation or just bagging somebody for a couple of minutes. You know, that's a sphincter tightening experience in and of itself. You don't know it's going to be just a couple minutes till it's over. So when you start bagging somebody because of an apneic episode, this is not a good shift. All right, well, is propofol safe and effective in the ED setting? Anybody had any bad outcomes with propofol? One, what did you have? Really?
Yeah,
cool.
And when I read about it, apparently that's been reported, and rhabdomyolysis has actually occurred. So I ended up having to give it every other procedural sedative in the book.
Interesting. So like an LSD sort of reaction. Now my question is, how did you know that was like an LSD reaction? A personal experience?
Not saying.
Okay. Yes, doctor.
Propofol has been reported to cause anticholinergic crisis. Would that have been consistent with what you were seeing?
You know what, I didn't really take a look, but his pupils really didn't look that big. But it's like he was seeing things, and I mean, he actually wasn't hyperthermic though, because we were checking to make sure that he didn't have a fever, and because we were checking the whole lab and everything, and looking for
The case report was not a pure anticholinergic crisis, but there was an abrupt reversal with administration of hypotension. So they thought it was consistent with anticholinergic.
was mentioned that, that there was a case report on anticholinergic crisis, in case you guys didn't hear it in the back. But your case sounds like a case report also. But again, we don't want to treat based on the enigmas and the zebras. This is a safe drug. All right, so let's talk about safety. Abstract number 2 is the best evidence report from the Journal of Emergency Medicine 2001. They looked at 4 randomized controlled trials with 266 patients for cardioversion, central line placement, and PEDS fracture reductions. And was it safe? Yeah, it really was. They looked at desaturation rates between Versed, thiopental, and propofol, and they were all the same. Decreased blood pressure was noted with propofol, and that's noted with many of these studies, but the overwhelming majority don't need treatment. And occasionally you need to give a fluid bolus. It's going to drop the blood pressure, but not into a zone where it's going to affect management most of the time. And central line placement, Versed versus propofol, desaturations, 2% of the time, but noted only with propofol in this study. And that'll be refuted with other studies and abstracts we'll talk about that really you're going to get a significant amount of desaturation and hypoventilation, probably more often with midazolam. PEDS fracture reductions was midazolam versus propofol, hypoxia, hypotension, and sedation scores were equivalent between the two. So what we're saying with this abstract basically is it's at least as safe as the other things we've been using. So it's not more dangerous. So what are the techniques for administering propofol? How do you guys like to give it? You guys go with the with boluses, or you guys go with an infusion, or both? Bolus. Infusion, anybody? If you're not as familiar with the drug, I think the safest place to start to get your feet wet is just start with the infusion. 5 mic per kilogram per minute, and you can titrate up to 50 very safely. And you can go even higher in some instances if you're not getting the response you need and they're stable. But if you're not comfortable with the drug, that's the way I would go first. And where I've evolved to at this point, again, whether right or wrong, I don't know, but this is, I think, a reasonable approach. If I've got somebody who is requiring mechanical ventilation and I just want sedation for that, unless they're just going crazy, I don't use a bolus. Just put them on the drip and titrate it up. Give the nurses some titrating orders. If you're using it for procedural sedation, and if you use the infusion without a bolus, you will wait forever to get them where you need to be. You'll be back in and out of the room a million times. If you stand there and give them 10, 20, or 30 milligram boluses of propofol, within a couple of minutes you'll be right where you need to be and you won't spend a lot of extra time. So that's a way to maybe differentiate how you would use it. All right, so look at abstract number 3. They looked at 20 patients, 18 to 65 years of age. They used a 2 mic per kilo dose of fentanyl, which is not a small dose for pretreatment, and then 0.21 milligram per kilo per minute of propofol till they noticed ptosis and slurred speech. So their eyes are shutting and they're getting goofy. So it's about where we need them to be to do most of our procedures. Then they put them on a maintenance drip of 3 to 6 milligram per kilogram per hour. Sounds a little complicated to me, but they could certainly do it that way. And they said it worked out very well. Apnea, less than 30 seconds, happened in 2 patients. That was the biggest complication. Mean recovery time was 6.1 minutes, so pretty quick. But I think this regimen's a little bit complicated for us. Abstract 4, 40 children, 2 months to 16 years. And it's interesting that they really are providing propofol to patients that are very young and having good success with it. 60% were for fracture reductions. They gave propofol with either fentanyl or with morphine. And then they gave the initial dose of 1 milligram per kilo to a max of 40. And then they would give additional supplements, 0.5 milligram per kilo to a max of 20. Desaturations, 30%, but only 1 for 20 seconds that needed assisted ventilation. That was it. So again, you're going to see this if you're using enough propofol, but what the studies and the data is telling us that rarely, if ever, will it result in the need for endotracheal intubation, airway management, and prolonged mechanical ventilation. It's not going to happen. Nearly 100% reduced their blood pressure, but IV fluids were only given to 2 patients. So watch the blood pressure, watch the apnea, but very rarely are you ever going to have to intervene. And 93 to 100% reported successful sedation. That's important. That's the end point. Is it working? Can we tolerate the procedure or the side effect profile for the procedure we're performing based on how well we're getting them sedated? If it works great, we can tolerate a lot of side effects if we know how to manage those. All right, what options exist for management of injection site pain? Just as I walked up here, these gentlemen were having a great conversation about it. You said that it burns when it goes in.
Oh yeah, big time.
Again, personal experience with LSD lady? You have any experience with this? No? Okay. But I've heard that as well. I haven't heard that from too many patients, though. Heard it reported in the literature. But you said you did have a personal experience with it?
Yeah, I had my gallbladder out in the IV site.
Wow.
Yeah, it was burned bad, but
I'm glad you mentioned. So personal experience, but not recreational. Definitely in the line of duty getting a gallbladder out. I'm sorry to disclose that information, but since you mentioned it. Well, what you can do is you look at abstract number 5. If you give a 0.5 cc dose of the 10 milligram per cc propofol solution, give that ahead of time, you'll reduce the pain at that injection, the later injection, by 13%. It's not going to completely go away, but you're less likely to experience that burning sensation. And my feeling is the minute they complain of burning, turn it up. Turn it up, and they will go to sleep quickly, and they probably won't remember it. They just didn't give you enough quick enough, I think.
Yeah, or reverse it.
Yeah, exactly, something, absolutely. All right, so what are the typical adverse events associated with propofol and their frequency of occurrence? We talked about the two biggies, hypotension and also hypoventilation or apnea. Those are the two big ones. But these next abstracts, 6 and 7, looked at all of the potential problems that may be associated with it. Abstract number 6 noted desaturations under 90% in about 7.7%, but here's the key point. It was not dose dependent. It's just an idiosyncratic response that some people have. They're just going to have this. So it's not like you should get more worried when you're giving the second or third or the fourth bolus. Yeah, you should, and be careful of the doses you're giving, but what this abstract is saying, it was not dose dependent. And with increased body weight and with increased age, they're more at risk for adverse events and desaturation. And we know you should be dosing this based on ideal body weight. There are not enough Twinkies in the world that are going to make your brain bigger and require more propofol. So it doesn't matter how big a person is, it's ideal body weight, which should be based on our dosing. All right, and hypotension, 3.5%, emesis in 1 patient, so it's not really producing a lot of emesis. And then bradycardia in 0.04%. It was 3 patients, and it spontaneously resolved. I suspect, although it was not reported this way, that it was related to those that did have a desaturation. You get hypoxemic, you might get bradycardic. Abstract number 7. They looked at 70% of patients were not fasting, 404 patients, and did this really matter whether they were going to fast or not? Was it going to produce emesis? And 94% were ASA class 1 or 2 patients, so what that's saying is they were very healthy patients to begin with. Again, 70% were not fasting. Fasting versus non-fasting, 0.8% versus 0.4% episodes of vomiting, no aspiration at all, and no difference in desaturations, increased end tidal CO2, or respiratory rates dropping below 12. So does this really cause vomiting? No, it probably doesn't. And this abstract speaks to a tangential issue that is, following the MPO guidelines, really all that important with procedural sedation. Well, based on this abstract, no. You look at an abstract we reviewed last year with ketamine use, and it's interesting, if you prolonged the NPO time period from 1 hour to 2 hours to beyond 3 hours with kids, they have higher incidences of vomiting. So you don't want to do that necessarily. So the NPO guidelines may actually be dogma that we don't need to follow. Okay, are these issues associated with or are there issues associated with routine administration of oxygen? Nope, there's no issue associated with that. The issue is if you don't give it, they're going to more likely going to have a desaturation. And the numbers are 18% of the oxygen group had desaturations, with 28% of those who did not have the supplemental oxygen. So you want to make sure you give the supplemental oxygen. And that was basically abstract 8. So how does propofol compare with other agents we use for procedural sedation? What is your favorite for procedural sedation? Is it propofol? Okay, a lot of you are saying yes. Where are the Etomidate people? I know you're sitting out there. Oh, look, it's Dr. Pacelli. Well, I'm here to try and change whoever feels that way. I'm going to change their mind that I think actually propofol has an edge. And hopefully we'll get people to change and move over this way. Etomidate's a great drug. But I think what Etomidate did for rapid sequence intubation, propofol has done for procedural sedation. I really do. I think it's great. All right, so look at abstracts 9 through 12, and they looked at propofol versus midazolam. Anyone using midazolam alone for procedural sedation? Doesn't treat pain much, great amnestic properties, and it sedates them, but lots of hypotension, lots of hypoventilation and desaturation, so not great. Abstract 9, 86 patients with shoulder reductions, and they compared the two, and the midazolam was even given with fentanyl, and still the ease of reduction was reported as 97.9% with propofol versus almost 93% with the midazolam and fentanyl combination. So that combination did not perform as well as propofol. And the key was they recognized that there was reduced muscle tone with the propofol group, and that's why they had the ability to reduce those shoulders much more easily. And full awakening, 6.8 minutes versus 28.5 minutes. So that's going to save us time in our EDs also. How many ankle sprains can you see in another 15 or 20 minutes? You know, maybe 1 or 2 can get in and out of your department in that time frame, so we don't want to be wasting bed space. All right, abstract 10 is a review of 4 randomized controlled trials. Again, Midazolam versus Propofol. They reported 90% efficacy for both, so they were equivalent in efficacy. There was only one major event, and it was really with the doc's choice. They gave propofol, they also gave an opiate, they gave a benzo also, and combined all of it. And we know when we start delving in polypharmacy and adding more than 2 classes and adding more than 2 agents in one class, we're really putting the patient at risk. So you start adding a bunch of medications together, and you're looking for trouble. That wasn't really an issue either with midazolam or with propofol. All right, 11 and 12 are looking at sedation for mechanical ventilation, as I kind of touched on earlier. In abstract 11, they had 88 patients. They gave midazolam 0.1 to 0.2 milligram per kilogram per hour versus propofol 1 to 3 milligram per kilogram per hour. And they looked at hours of sedation. 93% of the hours of sedation with propofol were without any issue or event. The patient was completely sedated. So 7% of those they had to resedate or give a bolus or something. And that's compared to 82% with midazolam. So 82% only of those hours did they not have to intervene and do something else. And abstract 12, 73 adults. They gave propofol 5 mic per kilo per minute, titrated to 50 mic per kilo per minute. That's the easy way to do it. And it worked great. They were basically equivalent at that point, but the awakening was better and more quick and prompt with propofol. So probably has an edge there for sedation as well. Number 13. Etomidate versus propofol. We've only got one abstract on this, but I think it's important and it speaks to that question about which might be better. 214 patients were looked at. Respiratory depression, there was no difference. There was greater myoclonus, no surprise, 20% versus 1.8% with the Etomidate. And that's why I really love Etomidate for rapid sequence. No downside for me at all, with the exception of maybe the adrenal suppression, and you have to be aware of that. But if they start to develop myoclonus in rapid sequence intubation, what do? Give the sucks. Yeah, it's easy, it's gone. When you're reducing a shoulder and you've got 4 family members in the room while you're doing this, and the patient starts twitching like a freaking cricket, what do you do at that point? Well, tell them, oh, this is all part of it, don't worry about it. And also, they start to tighten up a bit, you can't reduce the shoulder, and now you've got to give them benzodiazepines likely to stop this from happening, and you get to the situation where they might be oversedated and then need assistance with bag valve mask ventilation or even endotracheal intubation maybe. So when we have good alternatives, why do we run that risk with procedural sedation? So I'm a propofol fan when we're comparing the two. So taking a look here also, procedural success 97.2% with propofol versus 89.5% with Etomidate, so better success rate. And how about the combination? Are you guys using ketofol or a combination of ketamine with propofol? One over here, one here. You don't have to raise your hand anymore. Ketamine, that's so closely related to LSD. I pretty much know that you're probably, yeah, vitamin K, lady, yeah, you're back there. I know it. What color is the sky in your world? Is it purple, swirly stuff? I don't know. All right, number 14. They basically felt if you added some ketamine to propofol, maybe we could give less propofol and make it a bit safer. Well, not a bad idea, and actually there's some of these abstracts really state that maybe there is some truth to that. But is propofol really that unsafe if we're careful with it? It really isn't. But if you want to do this, it does work. 20 peds patients in abstract 14 with closed reductions of forearm fractures. They gave 0.5 milligram per kilo of ketamine and 1 per kilo of propofol 1 minute later. And discharge time was 38 minutes, transient desaturations in 3 patients, no bad outcomes. They said it was great. They gave repeat doses when they needed to at 50% of the original doses of either ketamine or propofol. They had no problems. This abstract just tells us it's a safe proposition. You can add ketamine to propofol in these doses and you won't cause a problem. All right, 15. This is a quick one for us. Ketofol, 6 studies were reviewed, and basically they found on their review that on these 6 studies that ketamine reduced hypotension and respiratory depression based on the ability to drop the amount of propofol that they were using. So if you're worried and if you're having a lot of experiences with hypotension or desaturations, then maybe this is the way to go for you and add a little ketamine to it. And remember, the old dogma that ketamine can't be given to adults, that's been disproved as well. You can give ketamine to adults, it's fine. All right, is propofol safe and effective in pediatric patients? Are you giving it to peds patients, or are you just giving it to adults? Giving it to peds also? Good. All right, abstract 16 to 18, I looked at this question. Abstract 16, 393 sedation events, aged 1 to 18 years. Narcotics and propofol were given. They had reduced blood pressures, 84%. It was transient. In 92% of them, it was less than 2 minutes, so not very long. Bradycardia, 6%, hypoxia, 5%, but the mean time was 1 minute, so very short again. If you hang in there, assist them or stimulate them, you should do fine, not have to do anything. Abstract 17 by Al Sacchetti, 1,028 episodes of sedation on 977 patients, 0 to 20 years. So again, some very young patients there. They did this with lacerations and joint reductions, and what they found with pediatrics was that still ketamine, when this article was actually published in 2007, ketamine was the #1 choice for emergency physicians 41% of the time. What's interesting, though, propofol was only there 14% of the time. So we've got midazolam, etomidate, and fentanyl ahead of propofol. I think ketamine probably is our agent of choice most of the time with peds patients. It works great. It's very safe. But we should be moving propofol up this list. We really should. And what's great about this abstract, too, they noted that 74% of the time, the emergency physician did the procedure and the sedation. And I don't know if you recall, at least for the U.S. docs, the Joint Commission got very nervous about this about a year and a half, maybe as far as 2 years ago. And they have not gotten much traction with this, but they were going to push the agenda that the person who was doing the sedation could not be the person doing the procedure. And you'd have to have 2 people there. And so that doesn't necessarily have to happen, but I imagine they're still trying to pursue that. But it's not come to the light of day for every emergency department at this point. All right, 0.6% of complications. 1 patient was hypoxic, 1 patient had apnea, so they found significant safety there. Abstract 18, randomized controlled trial comparing propofol with midazolam again, 91 children aged 2 to 18 years. The only difference was time to recovery, but again, that helps us. With propofol, 15 minutes for recovery, that validates what we said earlier, and with midazolam, 76 minutes. You can't stick them in the waiting room to wake up from their midazolam sedation. You can't do it. So they're going to occupy your bed, and it's not worthwhile to do that. So this is probably a safer and better choice in peds patients than midazolam. Okay, so how has propofol performed in specific clinical settings? Let's talk about some different things. How about MRI sedation? Well, we can extrapolate this to maybe CT. I love abstract 19. This makes me laugh when you read it. So, well, they had, intermediate dosage, low dosage, and high dosage patients. High dosage was 100 mics, 75 mics for the intermediate dose, and 50 for the low dose. And they said there was 0% of those patients had any movement at all when they had the high dose. So they had a whole lot of the propofol, microgram per kilogram per minute. So they had a lot of it. What they don't say at the beginning of the article, you find out later, is to get them ready, just to pre-sedate them a little bit for the MRI, they gave them halothane, nitrous, and oxygen. Well, I don't think they're going to move either. What's amazing to me is some of those kids who got the lower dose of propofol were still wiggling around. Boy, that's amazing. Give more halothane, I guess. So roll in the whole anesthesia circuit into the MRI suite, and let's put them to sleep. It doesn't make sense. All right, number 20 from the Cleveland Clinic, they looked at pentobarbital and propofol. Anybody using barbiturates like this right now for sedation, specifically for kids? Yeah, we had a lot of issues with those, particularly with hypotension and apnea. I don't think we're using much of it. Basically, they said that it was safer and also quicker recovery with propofol. Abstract number 21, it's interesting. Migraines. Has anyone used propofol for migraine headaches? The refractory migraine. Nope, nobody here. Am I the only one that did it? I did it once. And believe me, the hospital administration was not very happy, but I had this refractory lady at 2 in the morning. We tried everything. I'm like, you know what? I remember reading a couple abstracts about propofol. And the nurses were like, fine, we'll give some propofol boluses. And then it was not in the formulary of the recommended usages. So we had to do a little literature search and prove to them why this is reasonable in some cases. What they said in abstract 21 is these patients, 77 of them, were unresponsive to the meds they were already using. And they got pretty good relief with 20 to 30 milligram IV push boluses. And they actually had 82% had complete relief in 20 to 30 minutes. And the remainder of the patients, 18%, had 50 to 90% relief. So they actually got pretty good relief. It's one study that we're reporting here. But if you are backed up against the wall and you feel your patient has legitimate pain and you cannot break this migraine, you may want to consider this. Yeah, question?
Do you not look at bounce back migraine too? Like, do they, in terms of the pain relief duration?
Yeah, good question. She asked, did they look at bounce back, return visit with a refractory migraine? They have with several other medications. That's why the triptans I think are not great. They've got a 50% return rate within 24 to 48 hours, not great. But with this article, I don't believe they looked at that. I don't recall seeing that. It might be looked at by someone else, but I haven't seen it. But a good point. But you know, does it really matter? You're an emergency physician. They just have to get past 8 hours, right? And there's somebody else's patient. All right, abstracts 22 and 23, let's talk about cardioversion. I think it's great for cardioversion. Abstract 22 says they gave 1 milligram per kilogram, or they titrated 20 milligram boluses. It was safe and effective, and propofol was better than midazolam. And I think it's great. One of my recent experiences with this, I always like to ask patients when I've sedated them and they kind of go somewhere else, either on ketamine or propofol, what exactly did you experience? Where did you go? And most of the time, they don't know what's going on. They don't know where they've been or what they've done. Well, cardioverted guy in AFib, 45 years old, never had it before, only had onset of symptoms like 2 hours before, so felt comfortable cardioverting him. Well, he wakes up and he looks at me, and he looks at me again, and his wife's standing, and this is the scary part, his wife is standing next to him holding his hand, and he looks at me the third time and goes, "What are you doing in my tent?" And I backed up and I started getting this really weird broke-back feeling. And then his wife told me later they have a lake that they go to and they pitch a tent and they have this little piece of property, but it kind of scared me for a minute. This guy was absolutely convinced for 10 minutes after propofol that he was at that lake in a tent, and I was some new guy. I don't want to be the new guy, I don't. All right, abstract 23, 2 age groups. This is important. Less than 65 and older than 65. Propofol plus fentanyl, and midazolam versus fentanyl, which was better. The key was desaturations were really important. In the younger age group, less of them, with midazolam 18% versus 9% with propofol, but you get into the older folks, 65% with midazolam versus 19% with the propofol group. So again, above age 65, be careful with this medication, and midazolam is not a great medication specifically with this age group. So if you guys have any questions, I'll be happy to answer them. Otherwise, whoever's up next should be ready to go in a minute.